Okay, so inflammation. This is labelled with the suffix itis, arthritis, fasciitis, tonsillitis, tendonitis. So anything with itis is indicative of inflammation. You know this, I'm making a point. So basically inflammation is a chemical reaction to infection, disease or injury, and it's there to protect the tissue and then to heal it. The responses that are part of this process increases blood flow and tissue permeability. That increase in permeability allows migration of proteins, white blood cells and other protein structures to leave the blood vessel and enter the damaged tissue and start to deal with the infection or the injury. So whenever we're talking about an inflamed tissue, it should end up in itis. But we shouldn't be calling it a degenerative tendonitis. So itis is a different issue entirely. It's much more significant than degenerative changes, and it can be caused by a variety of medical conditions that need to be picked up as soon as possible and not treated for 3 weeks to see if we can get rid of the inflammation. We need to identify the cause of the inflammation if we can and fire it out. And if we can't identify the cause at all, we still fire it out. Degeneration is labelled with the suffix osis, arthrosis, tendonosis, fasciosis, and so on. Different process entirely. This is almost always mechanical breakdown, but there are some toxins that can produce degeneration. This is breakdown of the joint, ligament, bone, muscle, tendon, etc. You get degenerative muscle tears, degenerative ligament tears, arthrosis, and also pathological fractures. Caused by normal wear and tear, typically. Everybody gets it. We should be dead at 32, 34. We don't die because society keeps us alive, but the body wears out, and it wears out fairly early. The neck starts to degenerate at around about 12 years of age, and the lumbar spine around about 18. So you get an idea of just how long society is keeping you alive for. So it can be caused by trauma, macro trauma, micro trauma, or repetitive trauma. All of these can have their effect on the joint, and you see it in athletes. Athletes degenerate the joints earlier. Children athletes degenerate early and start getting adult problems in the form of biomechanical dysfunctions. It can also be caused by loss of dynamic protection, and it's arguable this is probably the biggest cause of the lot. So segmental facilitation, reflex inhibition, and neurological diseases where there's a loss of proprioception. All of these can end up in a form of Charcot joints. And you also have chemical toxins and disease process, diabetes with diabetic arthropathy, for example. Free blood in the joint or on the tendon or anywhere else, infections, unresolved inflammatory conditions that become chronic, and the joint will degenerate. So this is a mixture, but for most of that, what we do, it's about mechanical breakdown, looking for proximate hypomobilities, quadrant problems, neurophysiological problems. This is where we tend to look for causes of degeneration. Okay, so let's look at the causes of both inflammation and degeneration. First, inflammation. We have the systemic arthropathies and the reactive arthropathies. So rheumatoid, gout, ankylosing spondylitis, Reiter's disease, Crohn's disease, and so on, intrapathic arthritis. So these things will obviously cause inflammation as part of a bigger spread. So you're looking for other tissues to be involved, other joints to be involved, and so on. Diabetes causes diabetic arthropathy. These, I believe, are sugar arthropathies, sugar being a massive inflammant. So diabetes, it's often in the shoulder where you'll see this. Infections tend to occur at the knee mostly, but these are not consistent neither. Some infections will produce very acute infections that get rapidly very painful, and so on, red, hot, and so on. Whereas other infections, it's much more low grade, much more quiet. May not be very much pain, there may not be very much swelling. It's just sitting there quietly. Redness is a feature often of infection, especially the acute infection. So don't take redness as simply an inflammatory response. It's not. It's something more serious usually. And trauma, obviously you can get a traumatic arthritis, and your real problem there is, has there been massive damage done, or is this just a response to the joint bit to insult? And this is what you're going to try and figure out. So it's certainly traumatic arthritis, but is there other stuff undergoing changes in there as well? As far as degeneration is concerned, aging is the big one. Obviously, we all get older. Our bodies should have died when we're about 32. Society keeps us alive for longer, and the body just wears away quickly, especially when you're doing silly stuff like heavy activities, training for sports and so on. And you start seeing these changes, these degenerative changes also occurring in children because of overtraining. But generally speaking, aging degeneration tends not to be particularly painful. Certainly as you get into geriatric groups, then you start seeing aching, stiffness, and so on, but not enough usually to bring them in for treatment. So, as I say, there's no real evidence that degeneration caused by aging is particularly painful. Trauma can clearly cause aging. Fractures, intra-articular fractures, mal-healed fractures causing stresses on the joint afterwards, tears in muscle leading to degeneration, and so on. All of this can cause ongoing degeneration. Prolonged stress, micro trauma and repetitive trauma can obviously cause degeneration. And again, this is where we come back to these athletes overdoing things. Runners doing 8-10 miles a day, you know, they're begging for it really. So either the joint will break down or the bone will break down, or more usually it's both of them eventually anyway. Loss of dynamic protection, segmental facilitation, reflex inhibition, and neurological disease all end up with some form of Charcot type joints, because you lose control of the neutral zone. The neutral zone extends into the end zones, and then you start breaking down the end zone structures. Or you can damage the end zone structure, get pain inhibition, then converts to reflex inhibition, and that just keeps on going. So whatever the cause of this, that loss of dynamic protection can result in degeneration, both of the joint and of the tendons and the muscle. Unresolved chronic inflammation, that is unresolved acute inflammation that becomes chronic inflammation. Over time, this will lead to degeneration of the joints, and then all the stuff you see with it. Free blood, hemarthrosis, does not do well when it's inside a joint. Most body tissues don't like free blood. So hemarthrosis, if it's not dealt with fairly quickly, will rapidly degenerate the joint, as will chronic infection. So again, if this is not recognised for what it is and it just keeps going, then the joint will degrade. And the big example of this is tuberculosis. I can pretty much predict with 100% accuracy that if I ask somebody the clinical characteristics of an inflammatory tissue, they will come up with this. Tumour, dolor, calor, rubor. It's about the only piece of Latin anybody learns nowadays anyway. But let's go through these because it isn't as straightforward as that sounds. Swelling. Yeah, I think it's probably reasonable to say that any joint or tissue that's inflamed will be swollen. Now, that is not the same as to say that you're going to be able to feel the swelling. Swelling in a spinal joint, possibly the neck with somebody who's not too big, you may be able to feel that through the posterior spine. But everywhere on the spine, including the sacroiliac joint, you won't be able to feel it in the hip joint. Swelling isn't palpable, so whether it's there or not is debatable. And it's a bit trivial because you can't feel it anyway. Also, low level inflammations may not produce a lot of swelling at all, in which case, while the swelling may well be present in the joint, you may not be able to palpate it. So it's not that consistent. Pain. Yeah, pretty true in most cases, that there is going to be pain, and the pain tends to be more acute the more inflammation in the present. But interestingly enough, if some of these infections are not painful, about 25% of all septic arthritis are not painful. They don't present with pain. And this is why some of these chronic infections can go on for so long, because it's not particularly painful. Heat, probably again, but again, if a low-grade inflammatory condition, it's not likely to be high enough for you to feel the difference. And in the spinal joints, you're not going to feel it anyway. So again, this is a bit inconsistent. And redness really does indicate, without proof to the contrary, that this is either an infection or it's a systemic arthritis like rheumatoid. Otherwise, if you look at a traumatic knee, they tend not to get red. And if you see a post-trauma knee that is red, look for the puncture mark on in the area, because it may well be infected. Assume redness says infection, okay, and fire it back to the physician. So, yeah, if you've got all four of those, an inflammatory condition going on. If you've got three of them, there probably is, but if you've got none of them, you could still have an inflammatory process going on, especially in the spine. So it's not 100% certain, and these are not the most common signs and symptoms. Let's compare and contrast tendinopathy now. Tendonitis versus tendinosis. Again, the differences are exponential. Tendonitis is so much worse than tendinosis. So looking at the pain, it's sharp and severe pain on stressing the tendon. With tendinosis, it can be a sharp pain, but it's much less severe, and it's not as disabling. There is also no irritability with tendinosis, and there is with tendonitis. So this is going to ache for a while after you stress it. The pain of a tendonitis is sharp, and the aching is more generalized though. This is referred pain, presumably because of the intensity of the pain, of the nociception at least, and it doesn't follow a dermatome. It tends to radiate from that point outwards, so it spreads. Tendinosis, the pain is local. Tendonitis is a pain on active movement. If we look at a tennis elbow, for example, that's a tendonitis, then just doing this will hurt the patient. There's obligate functional loss with this, whereas with tendinosis, they can move fine, but it's only when you start stressing it more that they actually start to feel the pain. There's spasm on stretching the tendon. To one degree or another, it can be more or less severe, depending on how bad the inflammation is. This is usually, almost always, never present with stretching a tendinotic tendon. Painful weakness on minimal resistive testing. So with a tennis elbow again, for example, if there's a tendonitis, you just do that and it will give way as a scream, basically. Whereas a tendinosis, you really have to push on it, and then it may give way at the end of that. So it's by far not minimal stress testing to get that, of resisted testing to get that painful weakness. You have to put a lot of pressure through it. Whereas with tendinitis, almost no pressure will do it for you. It is tender, exquisitely tender for a tendinitis. You almost don't have to touch it. You can just run your fingers over the area and they'll be screaming about it. With tendinosis, you have to look for it. If you think about tennis elbow again, you're having to dig in there fairly deep until you hit the spot. That is definitely not the case with tendinitis. There may be effusion. This is tough to feel in a tendon, but if there's a synovial sheath around it, you might pick it up from that and you get contact inflammation. But the tendon does swell a little bit, but you may not be able to pick it up. There is no swelling, with no effusion anyway, with a tendinosis, but it may be a thickened tendon. Now, whether you can tell the difference between the two, I don't know. But certainly the tenderness, when you're palpating, trying to find this effusion or thickening, is going to be obvious. Tendinitis tend to be hot, tendinoses not. Causes of it, for tendinitis, direct trauma to the tendon, severe unfamiliar overuse. Now I mean severe unfamiliar overuse. Patients decide to paint the entire house in a weekend, that type of thing, and this will come on later. Or if there is no obvious cause for the tendinitis, then you have to start thinking about medical conditions systemic arthropathy and such. Tendinopathy, there's triggers, pretty much always a trigger to bring this pain on, but there's no obvious cause. The trigger isn't in itself sufficient to cause a problem. You can't say that a carpenter has got a tennis elbow simply because he's doing carpentry, because that's not unfamiliar to him. Something has changed either in what he's doing or internally. Something has changed to stress out that tendon more. Okay, looking at systemic or reactive arthritis versus degenerative arthropathy. These are the usual differences. It's not just about rubor, tuber, and so on. There's more to it. So, systemic or reactive arthritis, I'll group them as systemic arthritis. There'll be sharp pain when you stress the joint. And there'll be a bit of a continuous ache inside of it as well. With degenerative arthropathy, there may be actually no pain at all. Most degenerative joints, through age, wear and tear at least, are not painful in the least. If there is a pain, it tends to be an ache, a generalized ache around the joint. Systemic arthritis is irritable, degenerative isn't irritable. Both have generalized pain around the joint. However, you can have an arthrosis that is subluxing. Not all arthrotic joints have restricted range. Some of them are unstable and have more range than they should, in fact. These are the ones that tend to sublux, and these are the ones that we tend to treat, in which case the pain will be sharper and local. Spasm and fill on at least one of the movements with systemic arthritis, and no spasm with degenerative arthropathy. Effusion with arthritis, thickening with arthropathy if there is anything. Multiple joints involved, obviously, with systemic or reactive arthritis, and these are usually single joint arthrosis, or at least single region. Maybe the whole foot, but it's a region. With arthritis, systemic arthritis, the range of motion loss is obvious and painful. Severely painful. In fact, it's an obligate functional loss. The range of motion with degeneration may actually be full range, and otherwise there is a moderate limitation of motion. When it gets really bad, they're looking at replacements. So it's not a diagnostic dilemma for us. But the ones that do come into our clinic undiagnosed, then you're not going to see a lot of range of motion loss in them. And at the end of range, these will be usually stiff rather than painful, unless it's inflamed. With systemic arthritis, there's protracted morning stiffness, 2 hours or so, is usual. With degenerative changes, when there is a generalized aching, then there will be moderate morning stiffness, maybe 20-30 minutes. It'll take the time they get up, have a shower and everything, and by the time they're ready to move, usually that stiffness has eased off, and then it will come on again at night after they've done a day's work on it, if this isn't a symptomatic degenerative change. Other tissues involved with systemic arthritis, particularly reactive arthritis, but these are collagen diseases, so you'll see things like colitis, iritis, urethritis, fasciitis, other entities of tendons and so on. You won't see that with degenerative arthropathy. There may or may not be a temperature increase with systemic or reactive arthritis, and this is really about it'll be moderate if there is one. No temperature increase with degenerative arthropathy, and if you do see an increase in temperature, you want to start thinking this may be a chronic infection on top of the established arthrosis. So it needs to go out. Systemic arthritis is hot, red with malaise, degenerative changes, not hot, not red, and not malaisable. Okay, so I'm going to let this run over the next few minutes. I've got some flowcharts for you to look at that sort of summarizes what we've talked about, gives the information in a slightly different format, so it may be easier for some of you. But we'll just run through these without any audio. So let's look at osteoarthritis versus osteoarthrosis. First off, the terms are not interchangeable. They often are, or osteoarthrosis is simply not used. And osteoarthritis is used for every type of joint degenerative pathology. It's a mistake. Osteoarthritis is an inflammatory process. Osteoarthrosis is a degenerative one. Now, osteoarthritis is part of osteoarthrosis. So you do something to the hip, and the hip reacts to it. So in layman's terms, you'll sprain the hip, and you'll get a micro-traumatic inflammatory process, an arthritis. So the osteoarthritis is different from the background osteoarthrosis in as much as the pain is acute. It's fairly sharp, it's irritable so that you injure it, you do something to trigger the pain, and away goes the aching afterwards for varying degrees of time. So it's a severe sharp pain followed by an ache pain that is a result of irritability. You lose range of motion with osteoarthritis, very obvious range of motion, and you have pain at the end of that range of motion and often spasm. So this is an acute flare-up, essentially, of osteoarthrosis, which is characterized by either no pain at all, minimal limitation, typically, and or you have to find it with careful testing, and really no effusion. There may be thickening, but there's no effusion there, and no sharp pain and no irritability. So the difference between the two in its presentation are night and day, and the treatments are night and day. With osteoarthritis, you need to rest it, reduce the inflammation, deal with the pain. Osteoarthrosis, you're looking at prolonged treatment. So if the osteoarthrosis is asymptomatic and they don't have too many bouts of arthritis, you're not going to see this patient. They're going to go to the doctor for the acute flare-up, the doctor's going to deal with the drugs, and the osteoarthritis will subside and they're right. If they're getting a generalized ache, they may be sent to you to see this, to see them, in which case you're looking at a prolonged treatment effect, or you're hoping for one. So this is a matter of exercise, reduction, re-education, maybe manipulation, this thing is subluxing inside itself, and basically stretching. It's worth noting as well that osteoarthritis is not always about hypermobility. Osteoarthritis is, but osteoarthrosis isn't. These joints can be unstable rather than range deficient. So you're not always going to treat this the same way. Now, when they're not range deficient, they're mobile, then these are the ones that sometimes sublux and we can manipulate them. So that's the difference between the two. Don't use the terms interchangeably. Okay, chronic septic or infective arthritis. This is not the same as an acute septic arthritis. Acute septic arthritis comes on suddenly. There's a very rapid onset of swelling, severe pain, usually redness, and generalized malaise. The patient doesn't feel great, and there may or may not be a moderate to mild temperature raise on the patient. Chronic septic arthritis is a little different, and this may not make itself felt. Something like 25% of these are not painful. This can be caused by low-grade infections. TB does this actually, which is obviously not a low-grade infection, but TB is one of these more silent types of infections apparently. But this can be an infection that's been contained somewhat and become more chronic. And it can look very much like osteoarthrosis if it looks like anything at all. Now, if the patient's not getting pain, the chances are they're not going to come and see you, so it's not going to be a problem. So we're looking at the ones that are painful. The pain is going to be generalized. The most common area for this is actually the knee. So the pain will be generalized, and you're not going to see much in the way of swelling. There may be some thickening because this may have been a recurrence, or it may be on top of an osteoarthritic joint. So there won't be a history necessarily of invasions with implants or penetrating wounds. This seems to just crop up from sort of hidden viruses and infections and fungi. So this is not likely to be bacterial, it's more likely to be viral infectivity. it doesn't matter to you. It's recognising for what it is. So this may look like osteoarthrosis or osteoarthritis, osteoarthritis. And trying to tell the difference may not be that easy. Probably the biggest thing you've got is this is their first episode of this, or they may have had one some time ago. If this is an accompaniment of riders or Crohn's, it's going to be an older person, middle-aged anyway, and you're not likely to get this in the history unless you specifically ask for it. There may be a history of sexually transmitted disease in the past. So this is not the easiest thing to sort out. Definitely take the temperature. If you're not sure about this, if they are feeling a little unwell, take the temperature. And if it's still not making sense, take the temperature again. If the temperature is up, take it as a given that this is probably an infective arthritis until it's proven different by the physician. Not always the easiest thing to figure out. Okay. Alright, let's talk about language because it is important. I am willing to bet that if I took 100 therapists, asked them the signs and symptoms of plantar fasciitis, they would tell me that there is pain on weight bearing after prolonged periods of non-weight bearing, and that pain improved as the patient walked further on the foot. It's worse in the morning, it's worse after prolonged sitting, but it's non-weight bearing, really painful, and as it gets improved with a few steps. If you think about this, there is no other tissue that gets inflamed that reacts this way. If you have a hot swollen knee, the more you walk on it, the worse it gets. You have tonsillitis, the more you swallow, the worse that gets. You have laryngitis, the more you speak, the worse that gets. You have a tendinitis, the more you pull on things, the worse that tendon gets. This seems to be the only tissue in the body that improves with stress when you walk more on the inflamed tissue. And of course that's ridiculous. This is not a plantar fasciitis, it's a plantar fasciosis. Plantar fasciitis is often the result of systemic diseases, gout, ankylosing spondylitis, rheumatoid, and so on. And these things, the pain starts as soon as you weight bear on it, and it gets worse and worse and worse as you weight bear on it. That's an inflamed tissue. That's plantar fasciitis. We end up seeing plantar fasciosis, and the sooner these two terms are delineated and done away with, or at least used properly, the happier everybody will be. If I want to treat a plantar fasciitis, that's going to be done very carefully. If I'm going to use shockwave on it, it'll be very low dose shockwave, bring it up as we go. Similarly with ultrasound. If on the other hand this is a fasciosis, I can be a lot more aggressive with it. Same thing applies to tendinosis versus tendinitis. If I'm treating a tendinosis, I can really go to town on this. I can start using eccentric contraction exercises, deep frictions, manipulation. If I try and do that on the tendinitis, I should be done for assault in that case. So these are different conditions and they have different names. You have an overarching name on all of these. Arthropathy includes arthritis and includes arthrosis. Tendinopathy includes tendinitis and tendinosis. Fasciopathy includes fasciitis and fasciosis, and so on and so on. So there is an overarching name that describes a pathology of a particular tissue, and then when you know what it is, whether it's inflamed or not, then you put the appropriate suffix on itis or osis, but you don't use them synonymously. Stop doing it because it really does. It makes you look silly. I think the big takeaway here is language. Arthritis, tendinitis, fasciitis are inflammatory conditions. Arthrosis, tendinosis, fasciosis are degenerative conditions without inflammation. And the reason I know this is true, the language is important, is because I still see people using ultrasound on tendinoses, fascioses. I still see them resting osteoarthritic joints. So, and it's a natural thing to do. If you're going to call these inflamed, you're going to do anti-inflammatory treatments. This doesn't work on them. You need much more aggressive treatments with degeneration and less aggressive treatments with inflammation. also then leads you to suspect that there is an underlying medical condition when you do come across inflamed processes. So if I've got an arthritis, and this is an unexplained arthritis, it's not traumatic arthritis, it's just unexplained, then it should be assessed properly for a medical condition other than just trauma, which they have had. So don't just treat an inflamed joint because it's inflamed. You want to know why it's inflamed. Inflammation is simply a sign of an underlying condition. Same with tendinopathies. These are not always benign. These are caused by systemic arthritis, reactive arthritis, and so on. In fact, more likely, when you do get a tendonitis in, it's going to be caused by a medical condition that is by a non-medical condition that we are usually treating. So you're looking for evidence of either direct trauma to the ligament or to the tendon of the joint, or you're looking for unfamiliar severe overuse. Same with fasciitis. These things just don't get bad. So again, think about this as a medical condition. With tendinoses, arthroses and fascioses, there's often an underlying etiology there, which is either causing it or making it worse. So these are usually mechanical. You can find the neurophysiological effects of those mechanical blocks, and you can deal with those. So make sure that when you do get a degenerative condition, you look for etiologies, and if you find them, treat them. Okay, so